in this chapter, we're going to talk about conditions that the woman will have coming into the pregnancy that have the potential to put the pregnancy at risk. So chapter 20 is pregnancy at risk, pre-existing conditions.
Diabetes is considered the most common endocrine disorder that's associated with pregnancy and can have some pretty significant adverse outcomes if it's not managed properly. Now, the key to maximizing pregnancy outcomes in your patient with diabetes is going to be strict maternal glucose control. Because these pregnancies are considered high risk, using a multidisciplinary care approach will provide a broader base of care. You need to enlist skilled practitioners and providers from areas, ophthalmology, nephrology, your neonatologist definitely going to be there at the delivery, endocrinologist, because you want somebody who specializes in endocrine diseases to be able to manage in her OB care. In the ideal world, working with a patient prior to conception is going to be desired. That's what we want to do, because then we can plan, for when to get pregnant. We will be able to provide the education and stress the importance of, glucose control, and together manage the pregnancy and get those desires. Alrighty. The concept, the problem, what you see with diabetes is hyperglycemia. You've got an elevated circulating glucose, and this is stemming from something that's impacting insulin, okay? You may have a deficit from altered insulin secretion. The insulin may not be acting right, or the body may be resistant or insensitive to the insulin that's there. Sometimes it can be a combination of these. The process that should occur in the body is that the body ingests a food source, okay, and it's targeting that glucose. Insulin will then promote uptake of the glucose into the cells for energy. So insulin just kind of holds the glucose hand and walks it into the cells so that the cells can use it. In your diabetic patient, insulin does not perform the job. Okay, so instead of glucose entering the cells, the glucose stays in the blood, so you get the resultant hyperglycemia. Since the body doesn't have glucose for energy, those cells don't have their energy source, it's going to look to other sources, so it will turn to protein and fat as an energy source. When those products are metabolized, the end products are ketones and fatty acids. These can accumulate in the body, and you can have conditions of ketoacidosis and acetonuria. There are 3 broad categories of diabetes, one class being specific to the childbearing woman. Type 1 is your insulin-dependent diabetic patient. This is a patient whose beta cells do not produce insulin, and the onset is generally in early childhood. Etiology is thought to be autoimmune. However, the exact cause is unknown. A lot of research going on to try and figure it out. Type 2 diabetes is the patient who may still have some functional beta cells, just that the insulin secretion is reduced, and or the body is insulin resistant. The other group includes diabetes related to pancreatic injury or disease, or a drug-induced diabetes. The category that's specific to reproductive age childbearing women is gestational diabetes mellitus. GDM is diagnosed as any degree of glucose intolerance occurring with or because of the pregnancy. Now, if a pregnant patient has a history of diabetes, she is classified as a pre-gestational diabetic because that's a pre-pregnancy condition. With gestational diabetes, there are different approaches to care, in that some women will require insulin, some will require oral meds, and others can simply be diet controlled. Dr. White's classification of each group with diabetes is A1, having failed at least 2 of 4 oral glucose values, and treatment is diet. That manages it pretty easily. A2 is the patient who is not considered a pre-gestational diabetic, yet she needs medication, either oral or insulin, to control the diabetes. The pre-gestational is ranked based on different factors. So GDM-A1 diet, GDM-A2 meds, pre-gestational goes into different categories. Class B had the onset of diabetes after the age of 20 and has had the duration for less than 10 years. C is the onset between 10 to 19 years. D, onset less than 10 years of age or illness over 20 years. F has diabetic nephropathy. Group R has retinitis proliferans, and T has had a renal transplant. There is a chart in your book that writes all of these out for you, but what I want you to focus on is, especially with your gestational diabetics, your A1s are diet controlled and your A2s are medication controlled. In the first trimester, insulin needs will actually drop because the increased estrogen and progesterone stimulate beta cell production of insulin, and increase in insulin sensitivity is seen. If you are caring for an insulin-dependent diabetic, be aware that she may be prone to hypoglycemia as a result of these changes in the first trimester. Second trimester changes and effects of placental hormones start altering the body's response to glucose and insulin. Cortisol, insulinase, and other hormones act as insulin antagonists, causing insulin resistance. Insulin resistance is a glucose-sparing adaptation that allows the mother to have adequate glucose for the fetus. Your pre-gestational diabetics, they will need strict control and surveillance. It is not uncommon for pre-gestational diabetics who are either insulin dependent or non-insulin dependent. Either one will need insulin therapy and management in pregnancy. These women will fall into White's classifications B through T that we talked about on the previous slide. Insulin needs tend to steadily increase after the first trimester and may double or even quadruple before leveling off around 36 weeks. It's important to counsel the pre-gestational diabetic regarding management of meds, strict glucose assessment and control, and the associated risks of diabetes in pregnancy. You notice how there's a recurring theme of strict glucose control with your diabetics, okay? Macrosomia results from the mother's hyperglycemia and the glucose-sparing changes of the pregnancy. Macrosomia is your larger fetus, okay? The fetus will have hyperglycemia, which will lead to polyuria, which leads to hydramnios, or an excess in amniotic fluid. Polyhydramnios or hydramnios then increases the risk for preterm labor, premature rupture of membranes, and postpartum hemorrhage. In the graph, you will see insulin needs in the first trimester, okay? Let's take a look at that. From weeks 3 through 7, insulin needs will increase slightly, but then they're going to show a decline that starts around 7 weeks and goes to 15 to 20 weeks. Then the insulin needs will significantly increase up through about 36 weeks, and that's where the insulin need stabilizes. So you can follow the red line, and you can see the yellow line going up and down that's going to hit at about 36, and then 36 to 40 weeks, it's pretty stable. At birth, the insulin needs drop quickly back down to near pre-pregnancy levels. Remember, the baby's gone, placenta's gone, the hormones are gone. We don't have that glucose-sparing concept. If the mom is breastfeeding, her insulin needs will stay somewhat lower than the woman who does not breastfeed. We mentioned macrosomia and how polyhydramnios can affect uterine activity, promoting preterm labor, and uterine atony because it overstretches the uterus. But what does the effects of diabetes do to the fetus specifically? IUFD, intrauterine fetal demise, is still a major risk and concern for the woman with diabetes. In the last trimester, fetal acidosis is the most likely cause of the fetal demise. Congenital malformation is the most important cause of perinatal loss, accounting for 30 to 50% of all perinatal losses. Hyperglycemia in the first trimester, when the embryo is developing, so early on in those first few weeks, is the main cause of diabetes-related defects. So you can see why preconception counseling is so important. Okay? At 10 to 14 weeks, the fetal pancreas will begin to secrete insulin on its own. In response to maternal hyperglycemia, the fetus will secrete large amounts of insulin, which will cause the fetus to store excess glycogen, protein, adipose tissue, all of this resulting in fetal macrosomia. The macrosomia then leads to other problems such as shoulder dystocia, brachial plexus injury, acephalohematoma, or facial nerve injuries. So what do we do with the diabetic patient in pregnancy? Remember, priority is strict glucose control. Now, for some people, that's done simply with diet and exercise. The patient may attend a diabetes class to learn about food exchanges, blood sugar assessments, how to keep a food diary, what foods are best for her to take in, what foods are not good for, okay, what combinations can we have. In this situation, diet is focused on maintaining weight gain appropriate to a normal pregnancy. We want to prevent ketoacidosis and definitely minimize wide fluctuations in your glucose levels. The diet should be a mixture of carbohydrates, proteins, and fats. Now, 50% of the diet should be carbohydrates, complex, not simple. The remaining 50% should be split pretty evenly between your proteins and your fats. Exercise shouldn't be vigorous exercise, but it does need to be done, and it should be monitored by our primary care provider as well as her OB. Moving into insulin therapy, if they're used to once-a-day insulin injections, or if they've never had insulin injections at all, then they may need some additional counseling, how to rotate sites, how to administer it, things like that. The common insulin dose is 0.7 units per kilogram in the first trimester, and then adjusted to meet patient blood glucose levels. The different preparations for insulin are going to be rapid, short, intermediate, and long-acting. The most common type of insulin used in pregnancy is Humulin. If they're receiving insulin, typically they're going to get 2, sometimes 3 injections per day, but typically 2. And the way it's split is 2/3 of the daily insulin is given at breakfast and 1/3 before dinner. The mixture is 2 to 1, 2 being the longer acting, like an NPH, and then mixed with a shorter acting regular or Lispro. Blood glucose monitoring is done 4 times a day, fasting, and then either 2-hour postprandial or a 1-hour postprandial, whichever the provider orders. You want the fasting blood sugar to be between 65 and 95. Okay, so I'll say that again. Fasting blood sugar should be between 65 and 95. A 2-hour, we want it to be less than 120. A 1-hour, we want it to be less than 130. Hyperglycemia is less likely to occur, but it carries some pretty serious complication potentials for DKA, or diabetic ketoacidosis. Hypoglycemia, which can occur, is when her blood sugar drops less than 60. If this happens, you want her to, take in 15 grams of fast sugar. It can be a half a cup of unsweetened orange juice, half a cup of soda, regular, not diet, a cup of milk, or she can have 5 or 6 hard candies. After 15 minutes, you're going to check the sugar again. If it's still below 60, you're going to repeat that process. If it's over 60, you're going to have her eat something. You can check the urine for ketones to make sure that she's eating properly and her glucose needs are being met. If you get a high, urine glucose, don't freak out immediately. What you want to do is ask her what was the last thing she had to eat or drink and when was it, because it could be that she is just spilling from something that she just ate. If the patient is a diabetic that's hard to control, or she's non-compliant with her medication and diet, she may need hospitalization to get control of everything and education on how to keep it there. If she becomes hyperglycemic and develops DKA, that's an admission emergency. There is a correlation between diabetes and pre-existing hypertension or preeclampsia, which may need hospital surveillance. And fetal surveillance will include doing an early baseline ultrasound to make sure you have accurate dating, serial ultrasound scans during the pregnancy following fetal growth. At about 28 weeks, the mom will start doing fetal movement counts or kick counts. And then NSTs or BPPs, your biophysical profiles, will be done twice a week beginning about 34 weeks. And we're going to need to start talking about birth, how are we going to get the baby out. If there is much concern for macrosomia, a large baby, the recommendation may be for a cesarean birth, even though we prefer vaginal birth if at all possible. In consideration of fetal growth and having macrosomia, an induction of labor may be called at 38 to 40 weeks. We really want moms to go the full 40. We can say 39 is okay. Anything earlier than 39 needs to be medically necessitated. If there's any concerns, fetal lung maturity needs to be determined before delivery. In labor, the woman will be closely monitored to make sure that she doesn't have any hypo or hyperglycemic events. She's going to be using a lot of energy in labor, so she's probably going to get D5 once we go into active labor for her IV fluids. It goes without saying the fetus will be under constant surveillance with fetal monitoring while she's in labor. As nurses, we need to be alert for shoulder dystocias in stage 2. Okay. We've said insulin needs drop quickly at birth, so the insulin-dependent diabetic patient may only need a third to a half of her last pregnant insulin dose, so you need to keep an eye on that. Blood glucose levels are closely monitored, and sliding scale insulin dosing is going to be used to maintain target values after that. If she was gestational diabetic, she's going to need to have blood glucose testing done at her postpartum evaluation, and really even after that, because women who are gestational diabetic are at a higher risk for developing type 2 non-insulin dependent diabetes. So here's the breakdown for your gestational diabetes screening test. To begin with, everybody will do a 1-hour glucose screen, okay? And this is to see if she has the risk for gestational diabetes. She'll get a 50-gram load of oral glucose, and then her blood glucose is checked 1 hour after she drinks it. If the value is less than 140, she's past negative risk, she'll receive routine prenatal care. If the value is greater than 140, then we have to do the diagnostic 3-hour test. For this test, the first thing she'll need to do is have a fasting blood sugar drawn. So the prep is the night before at midnight she stops everything by mouth, no food, no water, no anything. She'll come in first thing in the morning. She'll have a fasting blood sugar drawn. Then she's going to drink a 100-gram glucose load. After that, she'll have her blood drawn on the hour for the next 3 hours. So say if she finishes it at 8:05 drinking the glucose, then at 9:05, 10:05, and 11:05 she'll have her blood sugar checked. So she'll have 4 results. She'll have a fasting, and then she'll have 3 hourly results. If she has 2 or more values that are above normal, she is diagnosed gestational diabetic. So she has to have at least 3 normals to pass the test. So in the slide here, you'll see what the breakdown of those values are. So she can miss 1, but if she misses 2 or more, then she is diagnosed gestational diabetic. Alright, so we're going to change gears now and talk about thyroid disorders. The incidence of hyperthyroidism is low, occurring in only 1 to 2 out of 1,000 pregnancies. When it does occur, the common cause is Graves' disease. So hyperthyroidism, Graves' disease, which accounts for 90 to 95% of all cases. Because the signs and symptoms of Graves' disease are also common pregnancy symptoms, the disorder may go unrecognized for a little while. The ideal is to look for specific findings. You may see goiters, tachycardia, elevated T3s or T4s, and very low TSH levels. If untreated, moderate or severe hyperthyroidism can lead to miscarriage, preterm birth, stillbirth, or infants with goiters or hypo or hyperthyroidism. Women with hyperthyroidism are at risk for severe preeclampsia and heart failure. Treatment is with PTU, propylthiouracil. PTU is easier to say. The dosing is 100 to 150 milligrams every 8 hours, and even though improvement can be seen as early as 2 weeks, full effect of dosing is reached by about 6 to 8 weeks. Your free T4 levels are drawn monthly to guide the dosing. Now, PTU does cross the placenta, so it can affect the fetal thyroid, causing hypothyroidism and subsequent intrauterine growth restriction. Beta blockers may be used to control maternal symptoms of hyperthyroidism as well. Now, if she breastfeeds, PTU does not concentrate in the breast milk, so breastfeeding is okay. The ideal, if you're breastfeeding though, would be to take the dose of PTU right after a feeding, because this gives 3 to 4 hours before feeding again. It is important to note radioactive iodine is not used in maternal hyperthyroidism because it may also destroy the fetal thyroid. So we do not use radioactive iodine to treat maternal hyperthyroidism. If maternal surgery is required to treat hyperthyroidism, it's best done in the 2nd trimester. Hypothyroidism occurs in only like 1.3 out of 1,000 pregnancies. Yet it is very critical to identify and to treat so that we can minimize fetal sequelae. The fetus relies on maternal thyroid hormones up until about 18 weeks gestation, so almost halfway through the pregnancy. So if her levels of thyroxine are low, then there may be associated abnormalities in your fetal brain development. The treatment is going to be with replacement hormone, your levothyroxine, and the beginning dose is 0.1 to 0.15 milligrams with adjustments of 25 to 50 micrograms every 4 to 6 weeks until it's normal, and we want to keep her at the lower end of normal. Okay, we don't want her at the high end, we want her at the low end, but we do want it normal. If untreated, pregnancy is at risk for stillbirth, preeclampsia, gestational hypertension, miscarriage, placental abruption, or preterm birth. PKU was the first inborn error of metabolism to be universally screened for. And since the early 60s, every newborn will get a PKU screening done. Early identification is important, so proper dietary management can ensue. We need to make sure we are restricting phenylalanine in the diet. Now, your woman with PKU will have her levels checked 1 to 2 times a week in pregnancy, and we want to maintain a target range of 2 to 6 milligrams per deciliter. High levels of phenylalanine are associated with microcephaly, mental retardation, and congenital heart defects. Major cardiovascular changes during pregnancy that affect women with cardiac disease include increased intravascular volume, decreased systemic vascular resistance, cardiac output changes during labor and birth, and intravascular volume changes that occur just after birth. While a normal heart can tolerate these changes, the diseased heart may not, and cardiac decompensation can occur. Cardiac disease accounts for approximately 15% of maternal mortality in pregnancy. In order to categorize the degree of disability associated with cardiac disease, the New York Heart Association created classes to readily identify the influence and limitations related to cardiac disease. While not absolute, the system aids the provider in determining the best course of prenatal care and surveillance with pregnancy as it progresses on. The functional classification of the disease is assessed and identified at 3 months gestation and again at 7 to 8 months. So, say that again. The functional classification of the disease in pregnancy is assessed and identified at 3 months of gestation and then again at 7 to 8 months. For the pregnant patient who does have cardiac disease, risk will be increased incidence of miscarriage and stillbirth, preterm labor, preterm birth, intrauterine growth restriction is pretty common, and the incidence of congenital heart lesions increase in children of mothers who have congenital heart disease. If she has an ASD, most likely the pregnancy will be uncomplicated. However, there is the possibility of right-sided heart failure or arrhythmias associated with the increased circulating volume. Coarctation of the aorta is ideally corrected before pregnancy. However, uncorrected patients can still have a successful pregnancy. The treatment will include rest and antihypertension meds, preferably beta blockers. Maternal risks of coarctation of the aorta in pregnancy include aortic dissection, hypertension, stroke, congestive heart failure, or aortic rupture. Fetal loss occurs in about 10% of these pregnancies. Tetralogy of Fallot is the most common cyanotic heart disease in pregnancy and is strongly recommended to be corrected preconception. If not corrected, the most important aspect of treatment is management and maintenance of venous return. Mitral valve prolapse is common and for the most part benign in pregnancy. Treatment, if it's needed, is going to be your beta blockers and education for your symptoms. Mitral valve stenosis is almost always caused by rheumatic fever, which is caused by inadequate treatment of group A strep. Damage to the valves or the chordae tendineae results in rheumatic heart disease. Aortic stenosis is rarely encountered as a complication of pregnancy. For all cardiac disorders, prophylaxis for bacterial endocarditis is given either ante or intrapartum. MIs are rare in pregnancy and occur most frequently in the last trimester of pregnancy. The risk of death most highly correlates to delivery within 2 weeks of an MI. So if she has a heart attack and has the baby within 2 weeks, that's where her risk of death is going to lie, or at least more so. Medical management would be the same as the non-pregnant female. There is an important note to remember that women with symptomatic cardiac disease in pregnancy should continue cardiac meds and receive oxygen during labor. Classic criteria for diagnosing PCM, or peripartum cardiomyopathy, is congestive heart failure during the last month of pregnancy or within the first 5 months after delivery, the absence of cardiac disease before the last month of pregnancy, and an ejection fraction that is less than 45%. The etiology of PCM is not known. Signs and symptoms will include dyspnea, fatigue, edema, and cardiomegaly. Management is similar to that for CHF, congestive heart failure. You're going to use diuretics and sodium and fluid restrictions. You're going to do afterload reduction and digoxin. C-section should be done only if medically indicated. Epidural for pain management to reduce cardiac workload. Inflammation or infection of the endocardium is treated with antibiotics. The woman with Eisenmenger's is advised to avoid pregnancy pretty much altogether, as the right to left shunting and other abnormalities often result in poor pregnancy outcomes and high mortality rates for both mom and fetus. The risk with Marfan is aortic dissection related to the aortic root dilation in the last trimester of pregnancy. Aortic repair is encouraged if the root diameter is greater than 5.5 centimeters, and the repair should be done before conception ever happens. If unrepaired and she is pregnant, management will include beta blockers and restricted activity. Vaginal delivery can occur if the aortic root diameter is less than 4 centimeters. Because Marfan syndrome is inherited, 50% of children born to affected mothers will have it. Now we're seeing an increasing number of people who have heart transplants successfully completing a pregnancy. They do need to wait at least a year to get pregnant after they've had a heart transplant. That's the ideal. Before conception, she should be assessed for the quality of the ventricular function and any potential rejections of the transplant. A vaginal birth is desired, but transplant recipients have an increased rate of cesarean births because we have to not overwork it. The neonate may exhibit immunosuppressive effects during the first week of life because of medications, and breastfeeding is not advised for infants of mothers taking cyclosporine. In looking at antepartum care management, a big thing to remember, signs and symptoms of decompensation are generally seen in the last trimester when hemodynamic changes hit their peak. So if you look, I have underlined greatest at 28 to 32 weeks as hemodynamic changes reach their peak. So that's obviously important. The signs and symptoms of decompensation should be taught to the woman at the first prenatal visit, and it should be reviewed every trimester. I want you to go to page 607 in your book, and I want you to see signs of potential complications and familiarize yourself with them. She should be able to differentiate between, the expected shortness of breath that's going to be seen in that last trimester and a persistent moist cough that's not associated with a respiratory illness. Okay? Because of bacterial endocarditis risk, upper respiratory infections, urinary infections, GI infections, all of these need prompt identification and intervention. You don't want the body being sick, okay? Cardiac meds are prescribed as needed with a focus on fetal well-being. Anticoagulation therapy may be needed. If so, we're going to use heparin, because it doesn't cross the placenta. A woman on heparin will have monitoring. We're going to do INRs and PTs. Now, if she takes in an oral agent, such as warfarin, we need to teach her about diet and to avoid vitamin K foods because we don't want to have any interference with bleeding and clotting. Assessment of placental sufficiency and fetal lung maturity may be needed if there is a concern for the need of an early delivery, either intentional or in response to a disease process. In labor, we want to support and maintain adequate cardiac function, so employing strategies to maximize oxygenation are going to be critical. As long as mom and fetus are stable, oxytocin can be used for induction, and a badge delivery is encouraged as the ideal whenever possible. To promote circulation and oxygenation, don't rest your legs in stirrups. Remembering that peripartum cardiomyopathy can occur in the first 5 months after birth, continued monitoring is essential. Care to promote oxygenation and minimize stress and exertion is important in the immediate postpartum period. To keep timely and specific assessment data, a Swan-Ganz catheter may be used to monitor cardiac function, and arterial blood gases will determine the presence of acidosis that results from maternal hypoxia. It stands to reason hemorrhage and or infection will affect cardiac function, so strict surveillance and interventions as needed will be required. If the mother does not have the energy to spare for newborn care, her support system may need to step in and perform menial tasks, but it's still going to be critical the mother stay in the loop of the newborn care with touch and speech. We want to promote that attachment and bonding. While breastfeeding is not contraindicated, again, she may need some assistance in holding or supporting the baby at the breast. We will need close management of her medications, say if she's on diuretics, to be sure that there isn't neonatal compromise related to those meds that cross into the breast milk. Education is going to be important for this patient, and enlisting the help of family and friends for her return home should be planned and implemented. Contraception should be talked over. Progestin products are considered safe and effective, especially if she has a risk for thrombus formation. We talked earlier, congenital heart defects, really of either parent, does put future offspring at risk for the same, so preconception and genetic counseling are important. Your pregnant patient is expected to demonstrate a physiologic anemia due to the dilutional effect from increased circulatory volume in pregnancy. However, if the hemoglobin is less than 11 and her serum ferritin level is less than 12, she will have iron deficiency anemia. This is treated with iron supplementation. Prophylaxis against anemia is typically 325 milligrams of ferrous sulfate, and if we're treating that, we're going to give her 650. Education should include what foods are rich in iron, that vitamin C enhances the body's absorption of iron, and milk or milk products will block the absorption of iron. So we just want to make sure that she doesn't ingest any milk or milk products 2 hours before or 2 hours after she takes her iron supplement. In pregnancy, folate deficiency is the most common cause of megaloblastic anemia, which results from the inhibition of DNA synthesis during red blood cell production. Folate deficits also pose the risk for neural tube defects in the fetus. Management is preconception counseling to hopefully prevent the deficit, making sure she does have a diet that's rich in folic acid, and supplementation with 600 micrograms a day. Sickle cell trait is the sickling of the red blood cells, but the red blood cells have a normal lifespan, 120 days. Most women are asymptomatic if they have trait and do well in pregnancy. However, genetic counseling is going to be required because we need to look to see if the paternal genetics increase the risk of sickle cell disease in the offspring. Sickle cell disease is a recessive hereditary hemolytic anemia. You have sickling of the red blood cells, but their average lifespan is 5 to 10 days. Sickle cell diseased women are at risk for miscarriage, intrauterine growth restriction, and stillbirth. Keeping hydrated will be critical as crises are usually triggered by dehydration and hypoxia. Women with either sickle cell trait or disease are at increased risk for UTIs, so frequent urinalysis and urinary monitoring is required. Women with sickle cell anemia are not iron deficient, and iron supplementation should be avoided to prevent iron overload. Beta thalassemia is a more common hemoglobinopathy that is seen in your Mediterranean, North African, Middle Eastern, and Asian descent populations. Women with beta thalassemia minor do not need antepartum testing and should only be given iron therapy if it is proven that they are iron deficit. Conversely, folic acid supplementation is recommended for all women with beta thalassemia minor. Patients with beta thalassemia major or Cooley's anemia will have hepatosplenomegaly and bone deformities and usually will die early in life. If they do make it to adulthood, infertility is common. Asthma affects 4 to 8% of pregnancies. Therapy objectives will be to maintain adequate oxygenation of the mother and the fetus, avoid or control asthma triggers, and use of drug therapy to minimize and treat airway inflammation, decrease airway hyperresponsiveness, and prevent asthma symptoms. To monitor the effects on the fetus, serial ultrasounds can be done in the pregnancy looking at fetal activity, fetal growth, and amniotic fluid volume. Labor is stressful for the mom, so having a rescue inhaler at the bedside is a critical component in her plan of care. Genetic counseling is going to be important for the woman with cystic fibrosis. Most men who have cystic fibrosis are infertile, but if they're trait carriers, they can, with a cystic fibrosis positive mother, produce infants with cystic fibrosis. Now, CF screening is standard at some point in a woman's reproductive years to see if she is a trait carrier or not, and to kind of help determine her offspring's risk. In labor, it's going to be necessary to monitor the fluid and electrolyte balances of the CF patient, watching sodium loss and dehydration. Oxygen is given by a mask, and SAT levels are continuously monitored. The epidural or local analgesia is preferred along with a vaginal birth. So now we're going to talk about skin disorders. Melasma, cloasma, mask of pregnancy, that's typically going to diminish and resolve with delivery and the loss of pregnancy hormones. Herpes gestationis isn't really a herpes virus at all. It gets its name because the lesions resemble herpetic vesicles. The lesions may appear at any time during pregnancy, but they most commonly develop during the second and third trimesters. There is a sudden onset of extremely pruritic urticarial papules and blisters on the abdomen and trunk. Pruritus is severe and unrelenting. Pruritus gravidarum is itching without rash and disappears shortly after birth. Your vascular spiders are little arterioles in the skin with radiating capillary branches that looks like the legs of a spider. We typically see these with increased estrogen. And by now, everybody should be familiar with striae gravidarum, what we commonly refer to as stretch marks. Alright, here's a list of skin disorders that are aggravated by pregnancy. Hormonal fluctuations in the first trimester often aggravates acne, but in the third trimester, the acne improves. Pregnancy is in essence an inflammatory condition which can trigger outbreaks of herpes or genital warts. Just read through the list. The big things to remember: your herpes, um, fever blisters, or your genital herpes, the timing of when they are, the education you want to give to your mom to make sure that she doesn't do anything where she can potentially transfer the virus to anybody, and we certainly don't want her getting it herself. Um, if there are genital warts, even if she has an outbreak in the perineum, the genital area, unless the warts are actually blocking the fetus's exit during birth, you will allow her to have a vaginal delivery with warts present. If she has a herpetic outbreak anywhere in the genital area, she will not be allowed to have a vaginal delivery. She will have a cesarean birth.
Pruritic urticarial papules and plaques of pregnancy, also known as polymorphic eruption of pregnancy, is simply referred to as PUPS. With PUPS, the abdomen is most often the area that's affected. PUPS can spread to the arms, thighs, backs, and buttocks, and in about 80% of the cases, the itching is classified as severe. The goal of therapy is to relieve discomfort, the itch, with topical medications, topical steroids, oral antihistamines. In severe cases of itch, oral steroids may be prescribed. There is no cure for PUPS other than childbirth, but the good news for mom is that PUPS does not generally recur in subsequent pregnancies. When you're looking at intrahepatic cholestasis of pregnancy, or ICP, what you'll see are elevated bile acids, elevated liver function tests. The disorder is characterized by a general pruritus. The itching affects palms and hands, palms of the hands, soles of the feet, legs, everywhere really. The itching is more intense at night. Women have been known to even claw their skin in their sleep. I have seen this once in pregnancy, and the patient just had excoriation marks on the tops of their feet, on their lower legs, around their ankles. It was so bad. Major risks of ICP are meconium staining of the amniotic fluid, so fetal distress, stillbirth, and preterm birth. The treatment is ursodeoxycholic acid, continuing to monitor LFTs, liver function, and the bile acids. Antepartum fetal surveillance is mandatory, and if the LFTs do not improve with treatment, then delivery around 36 to 37 weeks may need to happen. Again, we will always look at fetal lung maturity when we're making these decisions. Unfortunately, ICP can recur in subsequent pregnancies, and we've even seen it with the use of combined oral contraceptives. All right, so your neurologic disorders. With epilepsy, management of seizure activity is going to be crucial. You only want to use one anticonvulsant in pregnancy, and you want to use that at the lowest effective dose. Women with epilepsy should be encouraged to take a folic acid supplementation of 4 milligrams a day because of the increased incidence of neural tube defects in the women who take the anticonvulsants. Phenytoin is given during labor to manage seizures, and while anticonvulsants are found in breast milk, that is not a contraindication to breastfeeding. Neonates may have a risk for hemorrhage if they are exposed to the anticonvulsants in utero, because the anticonvulsants lead to vitamin K deficiency in the neonate. An education point for people taking anticonvulsants is that the anticonvulsants can decrease the effectiveness of oral contraceptives, so contraceptive management is going to be very important. With MS, you want to remember remissions during pregnancy are common. Bell's palsy, it's a acute idiopathic facial paralysis, 3 to 4 times more likely to be affected in pregnancy, and there is an increased risk for preeclampsia in the patient who has Bell's palsy. All right, so we're going to talk about autoimmune disorders. Lupus. Autoimmune antibody production affects skin, joints, kidneys, lungs, central nervous system, liver, and other body organs. It is recommended that the woman be in remission for at least 6 months before conceiving. Immunosuppressive medication should be discontinued before pregnancy. NSAIDs and aspirin are not recommended for use in pregnancy, even though they are recommended for inflammation of lupus outside of pregnancy. Specifically, if you are using aspirin, it should not be used beyond 24 weeks gestation because of effects on the fetus. Hydroxychloroquine, an anti-malarial med, may be best in pregnancy as it reduces disease activity and has not been demonstrated to have adverse fetal effects. Low doses of glucocorticoids may be used as well, and fetal risks are pretty much like most other disorders, stillbirth, IUGR, and preterm birth. Women with lupus should limit the number of pregnancies that they have. When we think substance abuse, it refers to the continued use of substances despite related problems in physical, social, or interpersonal areas of life. And due to underreporting, it's difficult to ascertain just what the prevalence of substance abuse is. What we have figured out is about 15% of pregnant women have a substance abuse problem. Now, any use of alcohol or illicit drugs in pregnancy is considered abuse. Okay, so outside of pregnancy, just continued use, but if you do anything in pregnancy, that is considered abuse. It's not always easy to get treatment. Less than 10% of women receive adequate treatment because of the associated social stigma, labeling that they will undergo, and the guilt of what they're doing here. There's also long waiting list and lack of health insurance that can have a further barriers to them being able to get the treatment that they need. So as nurses, what do we need to do? How do we get involved? Well, women who abuse substances may face criminal charges, okay? But we are there to be patient advocates, to advocate for this fetus that, can't do anything on its own, and it is not up to us to judge, okay? No matter what your personal feelings are, you have to put them aside when you're dealing with this patient population. We need to encourage them to have adequate prenatal care, to, seek assistance, counseling, treatment, whatever it takes for us to help mom and fetus have a positive outcome for this. That is what we need to do. And we need to use our voice, okay, and become involved in efforts to block punitive legislation against pregnant women who have substance abuse issues, who are trying to, come forth and get help that they need. So how do we, identify the people who have or are at risk for substance abuse? Screening is something that we should do on all prenatal visits. I'm an advocate for doing a urine drug screen on everybody on their first visit, and I don't pick and choose who gets it. Everybody gets it because it should be a practice standard. I have given counsel to clergy people about, don't drink alcohol, don't do this, don't do that, and they look at me funny, and I'm like, I treat everybody the same way. Every patient should be screened on their first prenatal visit, okay? Now, there is an assessment tool called the 4Ps Plus that it was designed specifically to identify pregnant women who might need in-depth assessments, okay? And the questions are very simple. You're going to ask about your parents. Did either parent have a problem with alcohol or drugs? Your partner. Does your partner have a problem with alcohol or drugs? Your past. Have you ever had beer, wine, or liquor? And then the pregnancy. In the month before you knew you were pregnant, how many cigarettes did you smoke? How much beer, wine, or liquor did you drink? This will give you an idea if there's anything to be concerned about that would need that further assessment. As I said, urine drug screens, I believe everybody should get one. For the neonate at delivery, if there is concern about maternal substance abuse, you can test the meconium in the neonate to see what the mom was taking. Substance abuse women are at a high risk for STIs because they have risky lifestyle behaviors. If drugs alter the menstrual cycle, or she is not a very good historian because of alcohol or drugs, then she may not recall when her last menstrual period was. So you may need to use an ultrasound to determine just how far in the pregnancy she is. I mean, you may get a woman come in who's not had any prenatal care at all, so you have no idea, where she is. There's no prenatal history to get information or anything like that. So an ultrasound is going to be pulled in for that. Lab assessments looking for STIs because of the association of her high-risk behaviors. Now, women are more receptive to making lifestyle changes during pregnancy than at any other time and are more likely to stop smoking during pregnancy as well as anything else. If she is dependent on heroin or other narcotics, methadone maintenance treatment for pregnant women is the standard of care. Now, MMT has been shown to reduce opioid or other drug abuse, criminal activity, HIV infection rates, and it has been shown to improve individual function. However, 30 to 80% of the neonates exposed to opioids in utero, which includes methadone, will require treatment for NAS. Cocaine use has increased dramatically, and women will need much support and counseling to stop this addictive drug. Methamphetamine users are also encouraged to stop just the same way we do with cocaine users. However, relapse rates with methamphetamine are high due to the psychological addiction to that drug. All right, so in follow-up with substance abuse. Now, we talked about it when we did infant nutrition that breastfeeding is definitely contraindicated if the woman continues to use amphetamines, alcohol, cocaine, heroin, marijuana, any drug product, okay? Before the baby goes home, you need to assess the home situation. You need to make sure the mom's not going to be at risk for relapse if she's gotten herself cleaned up by putting herself into a suspicious environment. You need to make sure that it is safe for the baby to go home to. Will there be adequate care and supervision? Is the environment a safe environment? You may need to enlist friends, families, or anybody to take care of the baby, meet that baby's care needs if the mom can't do it. If there is any concern about the infant's well-being and safety at discharge, then the case may very well be referred to Child Protection Services. I have known mothers not get to take their babies home with them. The babies have been sent home with someone else when there was that continued substance abuse. So that's the end of Chapter 20, pre-existing conditions. If you have any questions, write them down. We'll talk about them in class on Monday.